We're going to go ahead and get started. I wanted to welcome everyone to tonight's webinar. We've got a great topic and a great speaker. I'm really looking forward to it. I want to do just a little bit of housekeeping before we roll. For those of you who don't know me, my name is Lorne Lavine. I'm your host and moderator for this evening. We had well over 900 people that are registered for the webinar. It's obviously a very great topic. A lot of people are logging in right now. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Tischler can speak for as long as he wants to. We want to take as many questions as possible. One difference from what we've done in the past is that Michael said that he would not mind at all if people ask questions in the middle of the webinar. And so in the past, we've asked you to go ahead and type in your questions and we'll get to them at the end. But if you have some questions as we're going along, just ask them away and I'll hopefully not interrupt them too many times, but certainly try to get your questions answered. And of course, we are going to leave some time at the end like we always do for Q&A as well. In the next couple of days, you'll get a couple of things. You should get an email within the next day or two that has a link to download this entire webinar. It is recorded. Don't worry if you have to take a phone call or the kids are screaming, anything like that. You're not going to miss anything. Our sponsor tonight, GoldenDent, we want to thank them as always for participating. They're going to come on at the end and make a special offer. This is one in a many series that we've done webinars with them. They will also be able to provide continuing education credits, so give them some time. And when we have 900 people registered, obviously it's going to take a while to get to everything. Normally, when I want to introduce our speaker, I'll go through their entire list of accreditations and all the things that they've done in the past. And honestly, if I did that with Michael, the webinar would be over. We wouldn't have time for anything else. He's a diplomat of the American Board of Oral Implantology and Implant Dentistry. He's a diplomat of ICOI. He's a fellow of the Academy of General Dentistry, a fellow of the American Academy of Implant Dentistry, an honored fellow of the American Academy of Implant Dentistry, a fellow at Misch International Implant Institute. He's on faculty at Rutgers, implant editor and dental advisory board member for Dentistry Today magazine, editorial advisory board for Journal of Implant and Advanced Clinical Dentistry. The list just goes on and on. If I were to go through all of his speaking engagements and all of his publications, as I said, we would run out of time. Suffice it to say, he's got, it looks like well over 100 articles in print and speaks at all the major meetings. So without further ado, I want to introduce Dr. Michael Tischler. And Michael, we're looking forward to tonight's presentation.
Thanks, Lorne. I think the most important thing here is that I'm a general dentist, and I'm a general dentist with a big passion for implant dentistry. I gained that passion when I took Carl Misch's training about 20 years ago. And I'm here tonight to share what I've been doing over the last really 6 years intensely with Fullarch zirconia. And I want to share the surgical treatment aspects, what it is, extraction techniques, Alveoloplsty, grafting, and implant placement. And as I advance these slides, I'm just going to kind of wait for them to kind of appear. I just want to go through a few of the cases that we've done. And what I'll be showing tonight really is exclusively Fullarch screw-retained zirconia. And these are screw-retained monolithic zirconia bridges. And if you look at this case, for example, I mean, look at the before and after here. We are really changing lives. And, you know, we've personally done hundreds of these. I'm going to share with you that I have a dental lab that's exclusive to this one product. And I have a franchise called Teeth Tomorrow that focuses just on this. And I kind of fell in love with Fullarch zirconia when I opened up a dental lab about six or 7 years ago. And I just knew that acrylic was not working. When I first saw panoramic x-rays like the one I have up here showing this monolithic block of zirconia, it looked kind of awkward to me because we were traditionally looking at usually bar and acrylic or PFMs, and this is just one solid chunk of zirconia. I like to call it an aesthetic splint. And implants like to be splinted. It's very aesthetic, and it is very hygienic. I'm going to be lecturing on the main podium at the ICOI meeting in Vegas next week on peri-implantitis, and I'm going to share why I feel that this option of Fullarch zirconia is really perfect to avoid peri-implantitis. It has every attribute that you want. So I'm just gonna show a few more cases here. I mean, it's very aesthetic. It doesn't chip. I'll show you some of our studies. And in my opinion, this is the ideal way to change a person's entire life because it's not problematic. For us, when we did hybrids with acrylic and metal, we had nothing but problems. Some of our statistics show with 30 arches, about 10 of them had to be replaced with zirconia. It was so horrible. And we've just had over the last 6 years amazing success with this. So this is one last case. This is a 22-year-old female that Dr. Patch, who's my partner here in the practice in Woodstock, New York, that's where I practiced, about 2 hours north of New York. And we chose to, edentulate her and change her life. That's how much we believe in this. I just want to do some disclosures first. I do own a laboratory, Tischler Dental Laboratory. It's the only lab in the world that's focused on this one product, Fullarch zirconia. That's all we do. 25 employees. And I have a dental franchise. These are some of our employees. The franchise is called Teeth Tomorrow, and this is something that I started 2 years ago. We have 50 locations. I've got a private practice, so I'm busy. This is our book. It's a patient book, and this is what we do. So why we're doing this is because of this, baby boomers. There are 75 million of these people in the U.S. This is one of the largest segments of the population, born between 1963 and 1943 and 1962 or so, in their 50s, 60s, and 70s. And these people are active and they're living quality lives, and they don't want to go to the dentist all the time repairing their teeth. Every day, 10,000 of these people turn 65. So we have a large demographic population, and this is why I started this Teeth Tomorrow implant franchise for advanced implant dentists, because I wanted to address this with this solution that we found. Every day, 10,000 baby boomers turn 65. And if you look at this chart, this is pretty convincing. Here's 2018, and this is only going to get bigger and bigger as time goes on. I like to think of this as almost an epidemic. We've got all these people with dentistry, and a lot of this dentistry, most of it's done by great dentists, but there's an end life to dentistry. And as people are getting older, dentistry is eventually going to fail. And when someone's in their 70s and late 60s and early 80s and they're healthy, they don't want to do a full mouth reconstruction, especially when they have xerostomia and they're going to have decay inevitably. So when we look at these patients and they come in from advertisements, and Clear Choice has done such a great job of raising the consciousness of Fullarch implant dentistry in the U.S. with their millions of dollars in advertising, patients are really attuned to the concept of replacing failing or missing teeth. But I realize when a patient decides to edentulate their teeth with the advice of a dentist or working together with them, that's a pretty big decision, as we all know. Some of the things that we're looking at, and we're not in the business of just extracting good teeth, is what is the 5-year survival rate of the remaining teeth? What is the cost comparison to save those teeth versus replace that with a Fullarch zirconia bridge? And I'm going to show you in a minute that with the success rate we have, that paradigm of recommending to a patient to replace teeth. Now, sometimes it comes to be that there's a few teeth there that are savable, but it really doesn't make sense because they're in the way of a better solution. It's a delicate conversation. It's something that really needs to be looked at carefully. But we're looking at the aesthetic advantages, how compliant the patient has been in the past, what medications are on, what is the age of the patient. Can we change the bite with this zirconia bridge? And here you see the word Prettau. I'll explain what that is in a minute. That's a brand of zirconia that we've done. We can change the bite from class 3 to class 1. Is the patient ready for this? And that question really falls into the fact that a lot of dentists in the U.S., and I just lectured at the Florida Academy of Cosmetic Dentistry, and I kind of posed this concept to the almost 100 attendees there. A lot of dentists out there don't know the latest Fullarch options, that they're not comfortable talking to patients about Fullarch tooth replacement. They're still recommending overdentures, let's say, which I don't feel is the ideal option. And unless they know what's ideal, they're not going to have that conversation with the patient, and the patient's not going to be apt to do it. So it's my opinion that really doctors should really understand the latest. A lot of patients are just tired of endless dental work. They don't want to go through a year of treatment. I mean, 5 years ago, 6 years ago, 10 years ago, we were doing bilateral sinus grafts, and 1 year of treatment, one arch could cost easily $40,000 to $50,000, and this is not what patients want to do. The options that we're offering now are less expensive. We could do an upper and lower arch. Let's say on the lower right here, you see this panoramic X-ray. We can do that in 4 visits over a 6-month period, and this patient will have something that has what we've shown in the study I'm about to show you, a 99% success rate over a 5-year period, and it works. The big one is xerostomia and salivary output. When patients are on one of the 500 medications out there that cause xerostomia, that's certainly something to consider. We can create a uniform gingiva with this. We're talking about FP3, Mish's classification of creating artificial gingiva. This is a case, some of you may have seen me on Facebook. I like to post things and share my cases. Typical, another baby boomer saved today at Teeth Tomorrow, Hudson Valley, in my office here with Dr. Patch. Patients come in with these big bridges, they've had root canals, they've had aphicos, they've had these long span bridges, and when the posts snap, here you can probably not wonder why, because they're missing teeth on the lower right, and there's an imbalance of the bite. But when that happens, to put new crowns on these teeth, I don't feel is the right thing to do. And to be able to replace this person's missing, teeth in 4 visits over 6 months and have them in an immediate provisional the next day. We deliver a provisional the next day with the Teeth Tomorrow process, and I'm going to justify that in a minute why we do that. So this is just a post that was from Dr. Davis on Facebook, and I just like what he said here. We're talking about here is a shift in thinking. So many people have decay and perio problems. They spend a lot of money in the dental chair only to have these processes continue, and at some point they begin to think they're fighting a losing battle. So with this process, we're here to stop that losing battle. And I know a lot of my colleagues have seen this, where patients are just frustrated. This is not a slight against the excellent dentists that are out there. This is just nature. And I think we're fighting the ocean at times with some of the cases like I just showed. There are many patients in your practice right now that might benefit from something like this. So once you're aware of this and you could see some of these options, your eyes open. And it's years ago, 25 years ago, when I didn't do veneers, I was afraid to recommend veneers because I didn't know how to temporize and I didn't know the whole process. Once I was trained, I started doing more veneers. It's the same type of thing. This is the kind of thing where even if you're not going to do the surgery, you could affiliate with a qualified oral surgeon or specialist or general dentist that's adept at this and work with them. Because the prosthetic steps for these cases really are fairly simple because it's a uniform bridge and it's easily teachable. So you start to look at some of these patients that are coming in and they have teeth that can be saved in some situations, but instead of, if someone's decay prone, let's say in a case like this, instead of taking those teeth out and doing bilateral sinus grafting, then crowning anterior teeth, it might make more sense at times to dentulate that patient and kind of give them a new playing field. Very delicate discussion. This is certainly not the venue to dig into this deep, but I want to throw the concept out there. For instance, on this upper pan, I mean, when you have teeth that have posts in them and root canals and the patient's in their late 60s and you're talking about doing implants on the upper right here, doesn't make sense. The other issue here is when you do that and you do sinus grafting, let's say, or do implants in the dentulous area, you're now relegating this patient to crowns so that when the patient smiles in the future and the crowns do have to be replaced, 10 or 15 years later, which statistics show that's not unusual, now you're relegating them to an FP1 situation that's vulnerable to recession. With doing these cases like we're doing with zirconia, it's what Carl Misch called FP3, fixed prosthesis 3, where we're controlling the gingival area, and these patients will never have a recession problem. So you're kind of addressing a lot of problems at once. And I'm just kind of throwing this out there, just for discussion, well, not even discussion, just for the topic to be out there for you to think about. And we're looking at the lifestyle of the patient, financial aspects of their lifestyle, aesthetic criteria, So here's a patient that came in, for example, to our practice, and she said, I want my teeth replaced. And obviously, we're going to look in depth before we decide if that's the right thing. And as we looked at her, she had a long history of previous crown and bridge and veneers, and she was very decay prone. And she had gone through multiple rounds of having this done. And, you know, once we started looking at the radiographs and looking at her history, it really didn't make sense to do these crowns over for, I think it was the third time in the last, I think it was 10 years. It just didn't make sense for her. So once we took a CT, all these cases are planned with a CAT scan. We took x-rays, and she really was decaying out. And we decided at this point, it just wasn't right for her to go through root canals and have this done. And we ended up edentulating her and doing a zirconia bridge, which addressed her aesthetic issues, and it certainly addressed her decay issues. Because one thing I can always promise patients is they'll never get decay with these cases. And you know, it's the way we do things in this situation. It does require some training and understanding of the situation. What we do in our practice, our paradigm, is not to do all on 4 as our go-to protocol. I like to do 6 implants on the maxilla between the sinuses in general. This isn't really representative of the angulation I normally do. Normally I'll do a 30-degree angulation on the distal implants, upper and lower, and I go between the foramens on the mandible and between the sinuses on the upper with a 1-tooth cantilever usually. And that's the paradigm I like to do. I don't like to go distal to the foramens, even unilaterally. And by doing this, the patient has enough teeth, usually first molar occlusion, and they're able to chew and smile and live their life. TMJ is stable. It solves a lot of problems without doing bone grafting with sinus grafting or ridge augmentation, other than just filling in socket defects, which we'll talk about. And if you look at this, one of the key things that you're looking at here on the panoramic X-ray is the thickness of the prosthesis. I'm going to show you our Journal of Prosthetic Dentistry studies in a little bit, and that's based on our criteria of at least 12 millimeters of prosthetic height. And in a little bit, I'll show you how I do that. We do Alveoloplsty. We take away bone in order to achieve that. And we do 2 things when we do that. We hide the gingival zirconia junction when a patient smiles, and we offer the patient a thick prosthesis. So what you're looking at here is really ideal thickness, placement, and what has worked. And I'll show you that study in a second. So what I want to do this evening is, cover the background of what this is, an introduction to what the Prettau zirconia bridge is. There's different brands out there. We happen to use Zirconzon's Prettau. I'm going to cover some of the surgical steps. I'm going to cover just briefly maybe some of the prosthetics, but not really. That's what Dr. Patch does. So what happened was I had opened up a dental lab. We had a general dental practice here in Woodstock, New York, with 12 ops, and it was 4 hygienists at that point. I've now since sold that to Dr. Patch. I only do the surgery now. She does the general practice with her practice, Tischler Patch Dental. I have Tischler Implant Dentistry. But when I opened up the lab for that practice, we discovered this zirconia bridge by some doctors from Barcelona, and they handed Dr. Patch and I this solid chunk of zirconia in a bridge. And at that point, the Alveoloplsty brothers came to my office to lecture on their, they have an implant product, and they lectured on that, but they handed us this bridge, and a light bulb went off. And I took my current lab, and I converted it to do the Zirconium process. I bought all the machinery, and they came from Barcelona and brought this to us, and we decided to run with it. This is a Facebook post they did that was recently done 6 years ago. Our world changed when these 2 doctors came in and introduced us to this. And they've been doing this for years there, and they published it. We had a lot of problems with acrylic. We had an 80% success rate with acrylic when we did this. If you look at this article by Mallow, who is one of the leaders, this shows that he has an 80% success rate with acrylic, and he's got a 23% rate of peri-implantitis doing the all-in-4 acrylic in this article here, and that's pretty much typical. And when you look at acrylic, it isn't pretty. it attracts plaque, it fractures, and by doing this same bridge in zirconia, it really alleviates all those problems, because metal and acrylic are really not a good match. Someone just said to me that the metal that's inside one of these bridges is like a hammer that's always chiseling away at the acrylic, and eventually it's going to break. And that makes sense. There's no give. I'd rather see a patient in an overdenture that has a little bit of give to it on either a bar or locators, because you're going to get less fracturing of the acrylic. This is one rigid thing, and what's going to give here? The acrylic. That's the weakest part. So when you compare an acrylic bridge on the left with a zirconia bridge, it really is apples and oranges. They're just two different things. And when we first started doing this 6 years ago, and I decided I'm going to run with this, people were still confusing acrylic with zirconia. And I'm sorry, zirconia with acrylic, and they couldn't understand how it was that much different. Totally different. Acrylic attracts plaque. Acrylic chips. Acrylic doesn't look as good, especially after 6 months to a year when all the porosity attracts stains and stuff. This product doesn't. It's really the ideal product. So after doing this for 5 years in my lab with hundreds of dentists from all over the U.S. and Canada, Dr. Bidra from the University of Connecticut did a study of 2,039 arches that we had done. At this point, we're at 4,000 arches. And that study showed that we had a 99%, almost 100% success rate, meaning none of them chipped. 6 chipped out of 2,039, and we know why they chipped, because that was early on when the bridges were too thin. We may have layered some porcelain on it at that point. We don't do that anymore. So we have a very predictable product that my lab has learned how to do and has been doing now for going on almost 7 years. We then did another study with him in the Journal of Prosthetic Dentistry, peer-reviewed journal, showing 200 arches in private practice, and the numbers came out the same because of our criteria of the thickness, and it also showed a 98% success rate of the implants. Now, the implant success rate was just based on bone loss, and it wasn't detailed because it's very hard to get objective views of bone loss and peri-implantitis measurements, but it is 99%. Let me show you some of the things that we see on a daily basis. I had my assistant, because I'm lecturing next week, just grab me 5 cases of some of the early cases. These are 5-year post-op periapicals. And if you look at the bone levels here, I mean, they're right there. And we're not seeing bleeding tissue. We're seeing excellent bone levels. And this is just average. I didn't cherry pick 5 cases. I just said, let me have 5 of our early cases, and we're doing some of the recalls now, and here we are. And it's looking good. I happen to use BioRise as implants, but we certainly use many systems in our lab. But then look at the tissue. We're doing these recall appointments now where we're taking these bridges off when we do a screw check, and we're starting to take some photographs of the tissue. And you don't find this when you take off an acrylic bridge. I mean, I like to say it's like picking a rock up in the woods. There's all kinds of stuff under there. You don't find that with zirconia. You find clean tissue that's not bleeding, that's firm. And this is also based on the surgical protocols of how we set it up, too. Lorne, any questions at this point before I go further? I don't want to get too deep in here without...
We do have a couple, actually. We have one about what's your milling units for Zirc? Is it Zirconzon?
Yeah, I'm going to show that in a minute. Everything we do is through a company called Zirconzon, the milling machines, the scanners, the sintering ovens, which is an 11-hour process. I like this company. They've been around the longest. They're just about to celebrate their 10th year with this product called Prettau, which is named after a region in Italy. They're from northern Italy. It sounds German, Zirconzon, but they're from Italy. And I like this product. So we stuck with them, and I plan on doing that for a long time to come.
Okay. Another question, which I'm not sure if you're going to get to it later, but you were showing the case there, and obviously there's going to be some costs associated with this. What types of options are you offering for patients that can't afford the Prettau bridge?
Yeah, we're offering 2 options. In our office, we charge $32,000 for an arch. That's inclusive of extractions, minor grafting. We use an anesthesiologist. That's included. But we also offer a second tier pricing for a locator overdenture, non-splinted. And what I like about that option is it allows people to get into that $15,000 to $20,000 range but we set the implants up so when they want to upgrade to this, they can. That's one of the problems I have with, let's say, mini implants. There's no upgradability, really, to an ideal prosthesis. So we do offer two main options other than a denture.
Okay. And the last question, which is, we'll let you keep going, it's actually two questions, but it's kind of the same. How often do you remove and do a screw check, and how often does a denture need to be removed to be clean? So kind of the same question there.
Yeah, it's funny. The ACP, the American College of Prosthetics, just came out with a position paper very recently, and they don't recommend taking off these bridges, whether it be a hybrid or zirconia bridge or anything screw retain, unless there's a problem. And we've kind of subscribed to that. So what Dr. Patch does is she'll do a screw check to make sure the screws are all tight to, I think it's about 20 or 25 Newton centimeters. If they're loose, then we'll take it off. And that's where I'm showing some of these photos, and then we're replacing the screws and checking the bite and all that. But they're not taken off routinely on any level. The success of this is really also based on the surgical aspects on where I'll show you where we create a flat ridge. We create a convex ponic area so patients can just water pick this, and if they're really bored, they can floss too, but they don't really have to. And it stays clean, and that's what these bone levels and clinical shots show. I've never seen that with acrylic, and especially acrylic that has undulated areas that have food traps. It's a recipe for disaster and peri-implantitis problems, in my opinion. We do not see that with this. What we're talking about here, according to Mish's classification, is what's called Fixed Prosthetics 3, FP3. FP1 is when you do a cement retained bridge that has natural gingiva. We're replacing the gingiva. And if you look at this graphic from Carl Mish's textbook, you can see FP3 contains fake pink, and that's what we're doing. And to do that, there either has to be natural bone loss through periodontal disease, or it has to be done with a burr, and I'll show you how I do that, but that's something you have to do. The analogy is when you build a house, you do excavation for the foundation, and that's what you're doing here. That's part of our success. We're not afraid to take away bone that's needed to be taken away to gain the prosthetic height, the aesthetic results we need, and also set up the contours, and you're on better bone when you do that. So we're talking about FP3 here, just like you see here. And if you look at an FP1 situation versus an FP3, which we used to do a ton of FP1, I did that for years, lectured on it, published on it, requiring grafting, two-place implants, requiring sinus grafting. Implant placement is so much more exacting that each implant has to be in the right tooth position. When you talk about FP3, we don't have to graft two-place these implants. The implants have a lot more leniency as far as positioning goes, and it's just easier for everybody. So I really believe this is the way it's going. The other advantages are with FP3 zirconia is we're not talking about chipping. We're talking about the fact that we can unscrew this, and if we had to remill it, you can't do that with a PFM FP1 bridge. These are big topics here. I'm just kind of glancing over to give everybody an overview. So why is this ideal? Well, basically, it's CADCAM milled, so we're not talking about casting distortion. It's monolithic. The studies show that when people overlay porcelain on the aesthetic areas of the tooth, 20% of those chip. So we don't do that. You don't need to do that with Prettau zirconia. I've seen other zirconias from other labs that are not as aesthetic. This happens to be very aesthetic. We can customize the shape, the color, and all that. It's retrievable. We offer first molar occlusion. The screw access holes are strong and aesthetic. They don't chip away like they do with sometimes with PFM screw retain or acrylic. It doesn't attract plaque, and we're giving the patient a bite. Even if it's second premolar, it's still a bite. I think it's important for people to know what is zirconia. You hear zirconia, but zirconia is the metal. It's actually the oxide of the metal that we use. It's very prevalent. It's not an expensive element. And zirconia is then formed from the oxide into these pucks. It's actually zirconium oxide. And this zirconium oxide is created into a powder. And this powder is then formed into these pucks. And this is mined all over the world. It's very prevalent, zirconium. And once that's done, we could create a ceramic product, which implants are made of, bridges are made of, and we've all seen these zirconia bridges with porcelain on it for tooth-supported bridges. I have had some of those zirconia PFMs break because zirconia really is very rigid, and it's strong when it's thick. And this is why we advocate such thickness in these bridges and alveoloplasty. And once that's done, this product is here to stay. But you cannot be too thin. And that's especially true when you're talking about screw retain, because if there's any discrepancy from the impression or anything, and there's any kind of stress on it, it could break. But when it's thick enough, we don't see that. We don't find zirconia wears the opposing teeth any more than feldspathic porcelain or polished gold. That's in the literature, and that was a big farce years ago that people are going to grind away the opposing arch. Not true at all. This is from the company Zirconium, who I've been using. This is one of their pucks of that Zirconium Oxide, and this puck now is CADCAM milled. So I'll show you this process in a minute. There's different shapes of these pucks that can be used. We only use the flat ones, really, based on different thicknesses from, let's say, 15 to 22 millimeters. And this is the company. It's Zirconium, and I don't work for them. I'm just telling you what I use. The product that we use is called Prettau. It has a PSI of around 1,200 PSI. It's very strong. If you compare that, let's say, to some of the other products like what's a Zircon or all these from years ago, it's triple or double the strength of that. So there's really no comparison there to some of the other products that have been used in the past. This is a really strong product. We have all the, we use their milling machines, their stains, their sintering oven, which is a special process. It takes up to 11 hours. It heats, it cools. You don't want to fool around there. So if that isn't dialed in, you could have cracks, and we just don't see those problems. We use their scanner, so we use their products, and I've kind of hung my hat on them over the last 6 or 7 years, and it's really I bet on the right horse. And since I've been doing this, and I really brought it to the forefront, there's been a lot of competition out there coming out, but nothing is as proven as this product. And I like the company. So this is what we use. I just wanted to clarify that. It's a worldwide company. They're in various companies. They're not public, kind of a small company. This is the owner of the company on the right, Enrico. I'll be actually lecturing with him in New York in October for the first time, showing some of my cases. This is his son. It's a family company. I like the company. This is their milling machine. We have about 7 of those in our lab. So let me talk about this is their scanning machine, but enough of that. Let me talk about some of the, let me get to this. This is the CADCAM process. So what we do is we take an impression in the mouth. We take an open tray impression, splinted. The literature shows that a splinted open tray impression is quite accurate. And then we scan it. And from that point on, this process is a digital process. And we're designing this in a digital manner with their software. We're able to measure the clearance, the thickness, change the position of these teeth on a computer. And that's sent to one of their milling machines, just like printing, but it's milled. So it's sent to a milling machine, and the design is then printed on one of these zirconia pucks. And the design that we ascertain from the impressions that are taken and the indexing in the mouth is then situated in one of these pucks that I mentioned before. And this is a digital representation that's on the computer. And then this is sent to the milling machine, which is the same situation, and it's milled. Sometimes it's about 5 or 6 hours to mill an arch like this, but it's milled very accurately. We can measure, each puck tells you how much it's going to shrink. Once that's milled in the puck, it comes out in what's called the green state, which is what you're looking at here. This is a Fullarch in green state, 20% larger than the final product before it's sintered in the oven and shrinks. And at this point, we stain it. It's a little bit harder than chalk at this point, but once it's sintered, it shrinks 20 to 22%. And if you look at the bottom right, that is a very dense product. It's zirconia. It's almost like cubic zirconia. If you haven't held one, it's very heavy. We've never had one patient say to us, "This thing is heavy in my mouth." No one's ever told me that that's been the case, even though you would think it would be. It's not. It's almost indestructible as far as biting into things, and it really serves the purpose. One of the things that we've heard, and the question I get a lot on Facebook, is when you do zirconia over zirconia, are we getting a noise from the patient clacking their teeth together? The answer I can give is that in the JPD study we did with 200 arches, we had one patient complain of that, and it went away. The only time that really happens is if you don't ascertain the correct BDO, but otherwise it's not an issue. So that's a farce. 40% of our 200 arches were Prettau over Prettau with the same exact success rate. So it is not a contraindication. We do it routinely. So I just want to throw that out there, that is not an issue. These are the stains from zircons on to get some of the characteristics. These are acidic stains that go into the green state zirconia and soak in so that when you adjust it, it doesn't go away. We also glaze it. And this is what the final product looks like. You're looking at these titanium cylinders here on the top photo, and that's the interface between this zirconia bridge and the implants. And I'm not sure if I'm going to mention this in a minute or not, but one of the hot topics out there is, do we use multi-unit angle correction abutments? And in my practice and our studies, we only use multi-unit abutments when they're needed. And the only time they're really needed is in the anterior area when you want to redirect the screw hole from the facial of the teeth. We don't need it for anything but that. We don't need it for tissue height adjustments. That's all dealt with surgically. These are non-engaging hex component, non-engaging components that are bonded into the zirconia. We've had one cylinder come out of thousands of arches. It's not an issue. All right, so here's what I want to cover again, and let's talk about surgery. Before I go into the surgical aspects, let's just pause for a sec, Lorne, and see if there's any questions on the product itself and what I'm talking about here.
Yeah, I'm trying to see if there's any questions specifically. There is a question about, are you routinely putting people into night guards after restoration with or without a history of bruxism?
We are. That's a routine part of our process. At the end, the patient does get a lower night guard, and just as a protection. I don't know. It's just a preventative aspect of our protocol.
Okay. And is there a difference between the zirconia that you're using with your lab versus what other labs are using?
There is, and that relates to the filler content in the zirconia itself. So there's a lot of Chinese companies that make zirconia. I haven't seen long-term tests on that. The different filler contents also relate to the aesthetics of it. I found, for my purposes and what I've used, that the balance between the filler content, the strength, and the aesthetics for Prettau, and a lot of clinicians also feel that way, is really dialed in. And that's the reason I use it. The other thing I have to say about that is I really don't feel comfortable using a product that's not fully tested for years. When you do a full arch on a patient, that's a big deal. And you don't want to be babysitting problems and finding out that it's going to break later on. I know Prettau, they're in their 10th year, has been proven. I feel very comfortable recommending that for our patients and for the Teeth Tomorrow Network also.
Okay, keep going on.
Okay, so when I do these surgeries, I will do an upper and lower arch in my practice in about 2.5 hours total surgery time. From when the patient walks in to the time they leave, and then Dr. Patch takes about 45 minutes to an hour to take impressions, and the patient's out the door by noon when we do an upper and lower arch. I do these cases non-guided. For the FP3 cases where you're doing Alveoloplsty, I prefer to do them non-guided. There are some clinicians that prefer to do them with a guide, and it could be done both ways, and they could be done both ways successfully. I like to teach it non-guided. There's certain criteria that you do, how much Alveoloplasty, where the implants go. To me, it's very teachable, as is guided. So both can be done. But I do every case, when I do these cases in that time period, I use an anesthesiologist. And the patient's on propofol. The patient is sedated just moderately, and I'm able to focus and do what I need to do. That and some Versed sometimes. So I definitely recommend that when this is done. And let's see. So we use a pump, and I make sure that I can focus, and that's a big part of how I get this done in that time period. I've seen people take entire days on some of these cases. I'm going to share with you in a minute also how we do these cases, delivering the provisional the next day, and that's Teeth Tomorrow, and that's the protocol that we use. and I'll show you those advantages in a minute. Some of the general principles that I utilize when I do these Fullarch cases, we utilize an aseptic protocol. Having a implant franchise, which by the way is available to advanced implant dentists. There's 200 more locations in the US. If you go to teethtomorrow.com, you can see a map of where we are and what's available. These are large territories. But I like to recommend certain best practices to replicate the success that we've had. And a lot of this is based on an incubator type environment where we have the studies, we've done certain things, so we like to recommend certain things. One of them is an aseptic protocol. I do everything CT planned, whether it be guided or non-guided, mid-crestal incisions, full thickness reflection. I'll talk in a minute about how much bone reduction we do. I'm a big believer, excuse me, as a surgeon, to move as fast as possible. I don't think it's good for the patient or good for anybody to spend the entire day doing an arch. I've had people do that. I don't think that's the way to go. Good primary closure, I'll talk about that, especially when you're doing immediate load and you're suturing to healing caps. Anesthesiologist, and we use PRF growth factors. So these are some of the main principles that we utilize in our surgeries that has led to our success. I'm a big believer in an aseptic protocol. I've been doing this since day one that I've been placing implants. I think it's good medical legal protection. It offers a certain eloquence to the procedure when a patient is walked to the room with their driver or significant other. It's just the right thing to do. It's inexpensive. There's certain kits available. This is what we look like when we do our surgeries, and I'm really a firm believer in draping the room and the counters and doing a scrub technique, something that we've always done. And I think it kind of sets you apart. But this is what our rooms look like in our practice. There's certain kits available. We use one from Professional Sterile Systems. Salvin has one. Ace has one. They're available. This is a customized kit that we use from a PSS, and I just highly recommend it. So once you start doing this, it's hard to do these procedures, without doing it once you start, because it's the right thing to do. This is a serious procedure. You tie that in with the anesthesiologist in the room, the PRF, and you've got a situation that really is the standard of care. I mentioned earlier when I started how that, we're doing a lot of extractions in these cases, and the goal is to take teeth out and not take a lot of bone with it. Now, this isn't as important as if you were doing extractions on number 8 and 9 in a person with a high lip line to replace teeth between teeth. So you have a certain leniency to be able to take some bone away. In fact, you are taking some bone away with Alveoloplsty. Some of the key principles when you're taking teeth out in the situation is move aggressively. You don't want to spend 2 hours extracting an arch. It takes me on average about 10 or 15 minutes to take an arch of teeth out using the various instruments. And some of them are the golden forceps, which I'll show you in a minute. When I see crowns in the mouth, I don't remove the crowns by sectioning them. I actually take with the throw pack in, I take a forceps and I either take the crowns off from the teeth, I snap the crowns off at the gum line, or I take the roots out with the crowns, or I'll go back and then take the roots out after they snap off. But to tease crowns off, it just doesn't make sense. There's too much water, debris, and I find this to be a better way to go. The other thing that's a key principle here when you're doing this, two things. One is when you're doing a full arch of extractions, is to elevate a little at a time on each tooth. I kind of look at this as taking these teeth out all at once globally instead of taking one tooth out and going to the next. Because if you elevate on different teeth, you're allowing the blood supply to get in there, and they all kind of come out together. Anterior teeth, I do a lot of rotation with ash forceps, let's say. And I don't bother really sectioning the PDL per se, but I will go in with the 701 burr, just like when I do third molars, and I'll kind of trough it out and then take those teeth out as fast as possible. Expediency is important with this. You don't want the patient sitting there for an hour and a half and then going into implant surgery. That's when the whole day happens. There's different methods to take out teeth. I'm just going to focus on a few tonight, real briefly. And, I use elevators. I like the Luxator elevators. If anybody's used these, they're sharp. They get into the PDL and really take the teeth out. The other instruments I like to use are these golden forceps. It's a forced lever, as Carl Misch used to say, where we're perching on the bone and the tissue and kind of elevating the tooth out. I especially like the molar ones, and I like them for bicuspids, and they really are a major asset, these instruments. And if you haven't used them, I highly recommend them. And I would say it's a crucial part of my extraction kit. And the molar ones are really intuitive, and so are the bicuspid. The anterior ones I think are a little bit more delicate to use. I prefer rotation in the anterior region, but for the posterior teeth, I routinely use these. They have bumpers on them, and I didn't find them very hard to get used to. I do a lot of rotation with forceps. Here is a posterior ash in place. I wasn't using a bumper here. You can use a bumper, and it really just lifts that tooth out. It's amazing, especially if you do some PDL separation with the luxator, let's say in the beginning, and get that a little bit loose. It'll pop that tooth right out. It's like magic. I like these a lot, and this is what we're looking at. Once I get to this point where the teeth are out, what I do is I do a second CAT scan at this point, and I like to just rudimentarily plan the case now that the teeth are out, so I know if there's any bone loss. I'm in a current situation, and I throw some implants in the plan. I print that out, and I go in and I do a mid-crestal incision, flap, do my Alveoloplsty, and find the implant positions as I'm in the mouth, and that's what allows me to move. The other thing we use are growth factors. This is the interlock system, and growth factors are, I feel, important for healing, for soft tissue, hard tissue around the implants, and it's certainly not going to hurt. It's a best practice. It's inexpensive. It's easy to draw the blood. We use a butterfly, and when we do sedation, we'll do it right through the catheter itself with a 22 gauge needle, and it's centrifuged. It takes about maybe 10 or 15 minutes while the patient's getting numb, and we then add that back to the site. We take the plug that's centrifuged out. That's this fibrin plug with growth factors in it, and that's put into a proprietary dish they have, and the lids on it, they become flat, and then we basically apply them to the site, and it helps with healing. So those are the key factors as far as extractions. The other key point to this that's really paramount to our success is that we need 12 millimeters of prosthetic height. And when I say that, we're talking about this is just a prototype of a bridge, but I'm talking about at the thinnest aspect of the bridge. I'm not talking 12 millimeters from the flange to the incisal edge. The meat of that prosthesis should be at least 10 to 12 millimeters thick. I say 12 because if I say 12, people will give me 10 in the lab. If I say 10, they're going to give me 8. So, I mean, a solid 10. And when you do that, this stuff's not going to break. And you also gain the junction being hidden by having enough pink there, by having a thicker prosthesis. Realize that, one of the things people always hound on is this cleansable. Through doing the grafting that we do in the extraction sites and leveling the bridge flat, we're creating a flat ridge. This is not a concave surface under here that traps food. So I want to make sure that's clear. If you have thinner areas, that's a potential fracture zone. The other potential fracture sites on these things are when implants are too close. So one of the things about having our lab is I can actually, I have criteria. If the implants are too close, the prosthesis is too thin, we won't accept the case. So we have a level of monitoring where we know that if the criteria is met for thickness and spacing, the implants aren't over angled, let's say, we're going to have success. If you look at a CAT scan, one of the things that we do, and this is a take-home message here of what I do, and it's really a simple formula. What I do is I reduce the bone so that there's about 12 millimeters of bone in the anterior region on the maxilla. And I then place my implants as high up as I can, and there's my 12 millimeter implant, and then I will have enough prosthetic space at that point. I've never had a problem with over 300 arches that I've done and the thousands in the lab by doing this. So once again, I do my Alveoloplasty based on the CAT scan to 12 millimeters. I then go in after I flatten the ridge and made it so there's no sharp edges. I place my implants. I angle those towards the lingual, and I have success. On the mandible, what I do is I reduce the bone halfway down the socket. And if you reduce the bone halfway down the socket and you reduce the bone to 12 millimeters on the maxilla, you're not going to have a problem. I don't know if this is going to play. It didn't play last time when oh, it is. Lorne, can you see that video?
We sure can. A little, a little bit choppy, but we can see what you're doing. We can see you, see the bone being removed.
Okay, I'm just going to show for a second. So what I'm doing is I'm taking a special burr. This is some Axis, and I will reduce a ridge like this in, a couple minutes. It's not you're not prepping tooth number 19 for an MOD inlay here. Your job is to take away this bone. And I'm going halfway down the socket, for instance, on a straight handpiece, sterile saline, good evacuation, and I'm just taking that bone away. I know what I have to do. Now, to do this, you've got to visualize where the foramens are, so you're not taking those with it. That's not a good thing. But it's basically a standard protocol, and we're just reducing that bone, and that's what we do. So on the maxilla, for instance, we reflect the tissue. And when you reflect the tissue on the palate, that's fairly rigid tissue. You're going to pry that away, and you're going to go in there and just reduce that bone so that there's 12 millimeters. And how do I know when I'm at 12 millimeters of bone left? I look at the CT, and I can judge whether that's halfway down the socket, 3/4 of the way down the socket, and I basically eyeball it. It doesn't have to be that exact. I think a lot of people overcomplicate this. It's really not that complicated. You want to create a base of bone. You know your basic criteria. You have a good 3 millimeter window of height that you're still fine with, and you basically do it and go place implants. I don't mean to oversimplify it, but when you do enough of these, it really is routine, and it can be very simple. Once I reduce the bone, I then place my implants, and my goal is to place 6 implants between the sinuses. I can see where the sinuses are. I can put a pin in there and take a radiograph and double check that, which I do, and then I try to angle the implants to the sinus wall. I place 2 by the incisal foramen area, 2 in the most distal area, and then 2 in between. That's my 6 implants, and that could be in the socket. That could be between the teeth. It really depends on the situation. If you look at this photograph on the upper right here, you can see the distal implants are angled about 30 degrees distal in front of the foramens. And then I try to angle these anterior implants towards the cingulum of the teeth. So the screw hole is not going through the facial, then I don't need to use multi-unit abutments. Those are my basic principles of implant placement. I use BioHorizons. Many systems can be used. One of the things I do like about this system is it comes optionally with an abutment, and that abutment can help you see the different angulations you have that you want to do. It's almost like crown and bridge when you prep one tooth and you look at the next tooth. I like to use 3.8 millimeter by 12 implants, and this article by Baba shows that the 3.5 or 3.8s work as well as the 4.3s or 4.8s in the literature. This is how I find my sinus. I put a pin in, I take an X-ray, and I visualize where that is. If I'm where I am right here, I'm going to angle that a little bit. If I'm in the sinus, I move it mesial. If I'm too far mesial, I move it back. Once again, it's not complicated from a conceptual standpoint. And once you do it a few times, you really get it. If I do place implants in an extraction site, I'm not just obliterating that site. I'm placing this in fresh bone towards the lingual. The nice part about this, and look at the distal angulations there. That's what I want. I want nice 30 degree, not 45 degree angulations to maximize the AP spread. I want to be in fresh bone in that extraction area, or I may go between the extraction sites. And that's what I like about non-guided is I can flat that ridge and make choices. One of the problems I have with guided surgeries is that you're planning these cases prior to extractions. You're taking a rough estimate of the bone quality, and unless I can really feel it when I'm in there, I don't know for sure. I want to have that flexibility. So I'll then go into the lingual, and nature gave us thick bone on the palate here, and you can almost always find bone there. I mean, these cases are set up for this FP3 situation. I will graft with DFDBA putties, and I'll show you that in a minute. And I'll fill that in, and here I am. I'm angled towards the lingual. I probably won't have to use a multi-unit abutment here because the screw hole is going to be exactly where I want it. If it's not, I'll use a multi-unit abutment. I may use it on 1 implant. I may use it on 2. I may use them all of them in the anterior, but rarely. This is a typical situation here. You can see I've grafted the extraction sites. I've grafted any defects. I'm now going to have a flat hygienic ridge. I'm going to have keratinized tissue there, which I'm going to place. We're meeting all the criteria for success here, and that's why our studies have shown that success. That's a typical lowercase, 30-degree inclinations on the distal. Implants are directed towards the lingual. The mandible is a lot easier for that. Just showing you some typical cases here, upper and lower. Here's an upper case. And note I'm lingual. A lot of people, when they see me do surgery, they're surprised how lingual I am, but you want to be lingual. You want those screw holes to be towards the cingulum and towards the palate so that you're hiding those screw holes and it supports the prosthesis in the adequate way. Look at this picture, and this really represents how lingual I am in some of these cases, and this is what works. And if you look at this ridge, there's tons of bone here. There's bones in the socket, there's bones between the teeth. There's very few cases that I can't find bone. My bailout position, if the bone is not, I measure these with an ostelmeter to measure the stability, but if I don't get stable implants or I have to do a lot of grafting, I'll just bury the case and do it as a two-stage case and go back in 3 or 4 months, uncover the implants and move on from there. And they won't have immediate load. That's the worst case scenario. Well, the worst case scenario is I graft the ridge and then go back and place implants later on. So there's always a bailout, and the patient knows those options from the beginning. There's no surprises here. Once again, this photograph shows the lingual inclination of these anterior implants. There's bone on this palate, and I use it. And that's what makes these cases successful. Once again, another photograph showing the lingual placement of these implants. This is what works. And I know it works with zirconia. I guess it would work with acrylic and metal, but I'm not doing that. But this is what you need for screw-retained Fullarch prosthetics, is to go lingual, 100%. And when you look at these photographs, they don't have to be pretty. These don't have to be like perfect FP1 lined up. It doesn't matter. I mean, this stuff's going to be hidden. You're looking for structure here. When you see a beautiful building, let's say in New York or Chicago, you're not looking at the piers. How that's engineered is what's under the facade of what you're looking at. So you're on good ground. I do 2 CAT scans. I do a pre-extraction CT, so I make sure there's no pathology there. I send it out for a radiology report, and we do a post-extraction CT also, so I can see if there's any changes after the extraction. It doesn't have to be done that way. It's just something I do. I feel comfortable doing that, and it works in our workflow. So what we do is unique. I'm just going to finish up here in a few minutes here, Lorne, and we can take some questions. We discovered this Teeth Tomorrow protocol, which is the name of my franchise, of delivering the provisional the next day by accident. We were trying to rush a case and do a chairside thing, and all of a sudden it wasn't back from the lab, and Dr. Patch had to deliver the provisional the next day, and she said, wait a minute. The patient came back. The patient wasn't swollen. Provisional was done stress-free in the lab. The patient was home resting. So what we do is we take an impression at the time of surgery. And if you look at number 2, when the patient comes back, that tissue shrinks. Most people don't realize this, but the tissue shrinks the next day. And I suture the keratinized tissue to these healing caps. The tissue shrinks, patient comes in, and Dr. Patch will side book these deliveries. It's so predictable. She indexes. There's lots of nuances here to the prosthetic steps, and that's available in our training. But the tissue shrinks, and she pops in a beautiful provisional. The patient wears that, then we duplicate it. 4 visits. 4 visits, and this is what we do. So if you look at this protocol, here is her taking an impression on the upper right, and there's a lot of advantages to doing this. I'm just going to run through a typical case of delivering this the next day. This is the day of surgery, where I suture this tissue to these 5mm healing caps as a reference. The next day, the patient comes in, and it's amazing. The tissue shrinks. It's not bleeding. The patient's not in pain. We don't anesthetize the patient to take these healing caps off, and we deliver a provisional. Let that heal for 3 or 4 months, and recapture it and deliver a file. It's that easy. When you take off those healing caps the next day, the tissue's not bleeding. It stays up proud like this, and she's able to put the provisional in. It's something that most people don't know. It's easy to do. It's less chair time. I feel it's safer for the patient. They're home resting. They're out of the office. You're not tying up your operatory, And the lab is doing what they do best, making it provisional. And when you think about it from a clinical aspect, when the laboratory makes a polished, strong provisional, that's better clinical dentistry than a chairside, unpolished, not as strong provisional. And I think that there's substantiation to that protocol of what we do. Here's a typical case, upper and lower, and we extract the teeth. I reflect. These are the same steps every time. I reflect the tissue. The next thing I do is I do my Alveoloplsty. I place my implants. I do my grafting in between any defects so that we have good hygiene and good implant stability. I put my healing caps on. And I graft. I put my platelets there. And I'll talk about grafting in a second. I'm exclusively using only putties, and I'll show you which ones I use in a second. I then suture the tissue to the healing caps. And this is what we teach. Let's see, these are just some radiographs of the case. Typical case of hundreds that we've done using the same exact sequencing, the same exact protocols. What Dr. Patch will do then, the day of surgery, is she'll take the healing caps off and take an open tray impression. We use something called the mirror tray. She'll splint these impression copings. These are non-engaging impression copings in the posterior, and we use engaging impression copings in the anterior just in case we need to use a multi-unit abutment. The laboratory can then time those as far as the hexes go. So here's a typical case where this patient came in with a failing bridge. And this is what she looked like prior. Teeth were extracted. My screen's moving faster than the webinar screen. Teeth were extracted. Same sequencing here. I reflect the tissue. I then do my Alveoloplsty. I then do my Alveoloplsty. I place my implants. These are 6 implants where I found the bone based on the CADCAM. Same situation every time. And then we take an impression. And this case now is 5 years old. And whoops, I just want to get done here in a sec, Lorne, and get to some questions here. This is Dr. Patch in a second taking the impression. We splint these with floss. We put composite, flowable composite that's dual cured in between to stabilize it. So we've effectively created a splint. She light cures this, sections it. She'll verify it. And the laboratory then will take that impression. She'll index that on the healing caps, and then the laboratory will create a provisional, and we'll deliver that the next day. And so, for instance, this case is 5 years old and functioning well like these other cases, and this just works. Just works. All right, let me get to some questions in a second. Oops. And that's what the case looks like. Immediate load next day, very aesthetic. Patient has an ideal solution. Problem solved. This is the pink gingiva. So this is typical of what we're doing. I just want to real quickly cover bone graft, Lorne, and then we'll finish. I use donor bone, which is allogenic bone. It's got osteoinductor properties. This is an article I wrote in 2009 on the advantages of putties. And there's a few different putties that I use. One of them I use is, oops, there's advantages. They don't migrate, they're hemostatic. This is a list of, now this webinar is recorded, Lorne, so I guess people can go back and check this out too. But it has a lot of advantages to using these putties versus particulate. And there's different carriers involved. One of the products I like a lot that I've been using for years is from Zimmer. This is a frozen product on the right that I thaw out in a water bath, and I kind of mold it. And I have to tell you, it's almost the equivalent of doing similarly a block graft. It actually forms space. It maintains the space around it and turns into a D2 bone. This is a case I just did with the Zimmer product. This is a 1 cc piece of Regenovate that I've kind of heated, and I'm going to mold this. I've been using this product for about 20 years, and I mold it on the ridge. And when I uncover this, you can put a denture on this. And when I go back, you know, I've done so many of these cases that this turns into D2 bone, and I'm able to place implants. Another product I use, which is a putty, is Dynablast, which is a putty I use that's in a syringe. Very simple to fill in defects. I don't use this for substantial bone growth, but I use it for filling in voids like this. And then I also have used GoldenDental's product, which I'll show you in a minute. I had it. Where is that? GoldenDental has a grafting product that's also a putty that's used similar to the Dynablast. You can put in there and fill in the voids also. Suturing is important with these cases. You want to put the keratinized tissue around the healing caps, you know, for peri-implantitis problem avoidance. And that's a key part of this whole protocol, is suturing the tissue and getting keratinized tissue there so that we have something that looks like this. This is typical to what we're looking at when everything heals. The platforms are not deep, there's no bleeding, there's good keratinized tissue there, and it's going to be around for a while. So Lauren, that is it. I'd like to field some questions if possible.
Yeah, well, we're going to turn things over to Kurt right now. You know, so much of what you talked about is related to the surgical aspects, and we're very fortunate to have Kurt Lawler from GoldenDental, who's going to present us a little bit about what they do to make that process easier. We're probably going to be a little short for questions tonight. I've got to stop in about 10 minutes or so, but Kurt, take it away. We're looking forward to what you have to tell us.
Sure, Lauren, I appreciate it. I'll try to keep this brief so we have some time for questions here at the end, since we're just running a little bit behind. Dr. Tischler, thanks for your presentation this evening. I really enjoyed it. I know we've got a lot of dentists that are on this evening that join our regular webinars and have hopefully enjoyed a little bit of a different topic this evening, going over what was presented this evening. So if you're not familiar with GoldenDent, you know, we have the slogan of practice different. I just wanted to give a little bit of background about our company and kind of what we do. If you're new to our company and have not used GoldenDent in the past, is we have unconventional dental products, you know, for common dental procedures that can be sometimes frustrating the dentist, whether it's you know, crown removal, implant spacing, extractions, more simplified ways to do bone grafting. We have various different products which are unique, and the products that are just sold direct through our company. So we are a family dental business. We've actually been in the dental industry in our family for 80 years. And so these are some of the Dr. Golden's ads that were in the Detroit News here in Detroit, Michigan, from the 1940s, and it was just kind of fun and interesting to see some of these old ads here from 115 State Street, where extractions and fillings and some of these various procedures were offered for $1. And so it's just fun to look at some of this history that we have with our company, and we use that history to produce products that are good products and that clinically work. I'm going to go ahead and I'm going to provide this first this evening because I know some of our regular webinar joiners do join our webinars to take advantage of some of the promotions we offer. We appreciate that you've invested an hour with us this evening, and we do provide promotional offers just for investing your time. And if you're interested in any of our products, we do offer the promotional codes that I know our regular webinar joiners do use on a regular basis. So the promotion is 15% off on any of our GoldenDent products or educational programs. And the promotional code is TODAY15. So it says TODAY15. And you can take advantage of that promotion online or by giving us a call in the office tomorrow. It's just it's physicsforceps.com is our website. The physics forceps is what started our business back in 2007 for the GoldenDent aspect of our business. And this is our standard series set of instrumentation. Dr. Tischler mentioned the molar series more this evening, which I'll go over here next. But this is really our most popular set of instruments. This set will work second molar to second molar on the upper and lower. There's actually 3 upper instruments and 1 lower instrument. They rely on the concept of leverage. It's a beacon and bumper concept. And even though it's called a forceps, it's not a forceps where you squeeze. It's an elevator. And so you want to hold it very lightly in your hands, and you're elevating the tooth up and out of the socket. This instrument set is what I would recommend if anybody does want to try the physics forceps. The standard series is normally our most popular set. We find that they actually are easier to use just because it's a simple up or down type motion with the instruments than our molar series instruments, which I'll show you here in a second. These instruments always have a 90-day money-back guarantee on them. There's really no risk to ever try our products, and this is one of the ones that does have the 90-day period on the product. These are the molar series. I know Dr. Tischler mentioned he does like to use these just more for the posterior region. These do allow you to get further back into the mouth. It gets around the cheek restriction where the instruments I just showed here, you're going to have some issues sometimes getting back to a second molar and definitely an erupted third molar just because of the angulation that they come into the mouth. And this is where this set's going to allow you to get a little bit further back into the mouth. It has a thinner bumper because there's just not a lot of room in the vestibule back there. And these allow you to get a little bit further back. However, I do find these can be a little bit more technique sensitive than the standard series instruments, but they do get further back and aren't going to really provide you the leverage that is quite as good with the standard series that I'm showing on the screen here. Again, quickly, I'll get through this quickly here, but I just wanted to show we do have a full line of extraction instrumentation. These are some of what we call separators. These are quite popular. There's just a bayonet, a straight, and a curved, which sometimes doctors like to use these in advance of the physics forceps, or if maybe you have a root tip, or if you prefer to elevate the teeth out of the socket, this is a good alternative that we have. This is a newer instrument that we came out with. We call it the wedge, and this is actually a good pre-step for anybody that is already using the physics forceps that's maybe looking for a good instrument to maybe elevate a little bit in advance, or if you want to be very careful in the anterior region or where the buccal plate is very thin. This is a great instrument that you can use in advance of the physics forceps, where you can kind of push it apically and wedge between the two surface and the bone and start to sever the PDL. So this is a new instrument for anybody that maybe hasn't been to our website in several months or hasn't been there since our last webinar. This is a new instrument that you can take a look at. Same with this instrument, we call it the reflector. This is really great for if you're doing some of like the Fullarch type cases. This is another instrument that's new for us where it allows for easy retraction of larger areas of soft tissue. This would be another instrument that is new for us if you haven't, again, been to our site recently. This is something that you could take a look at when you get time on our website if you're interested. So for our bone products, this is our allograft, which is Goldas. I know Dr. Tischler said he exclusively uses putty. We do have this in a particulate and a putty format. You can compare to your allograft brand. It does provide really good clinical results and has a fair price. Our particulate has actually through our bone bank has an innovative technology that they're implementing and how they're cutting the allograft. They call it like a rice-shaped fiber technology, which allows it to resorb at different rates based on the different cuts of not being all the same size of the particulate. This is our putty, and one thing that's quite interesting is if you look at the bottom right there, what's nice about our putty is actually it's 100% DBM, which is great, but it has the cap there in the bottom right, which is nice, where it allows you to have two different ways for the flowable aspect. You can take the white cap off completely and have the putty come out, I guess, sort of thicker or more at a time. Or you can actually just unscrew the small little cap at the end, which is kind of nice and gives you a little bit more control during the placement aspect. This is a product, I guess we can get Dr. Tischler's opinion on it when we're done, but this is actually very popular for us here at GoldenDent. This is more though for, I guess when you're doing single socket preservation where all your walls are intact, or if you have a 4-wall defect The Osteogen plug is really a great product. We, again, sell a lot of this product. It does very well for us, and our doctors are very happy with it because it is a really affordable option for grafting when you have a 4-wall defect, where with the promotional pricing tonight, I mean, it's $42 a bullet. There's no membrane required. You just cross-suture it in place. But again, we don't really recommend this, though, if you have like a defect or if you do not have all your walls intact. You should still probably use a membrane or particulate or a putty type conventional type graft. One other thing about this product real quick, so it's a synthetic bone, so it's not just a collagen plug. So it's a calcium apatite crystal is actually mixed with a bovine Achilles tendon. So it's actually like a hybrid between two different types of bone graft, or bone graft and two different types of, or two different categories of a bone graft, which really makes it unique. There's nothing like this product on the market currently. Here it is. You can go ahead and cut it to shape. Just snip the bottom of it. You can go ahead and place it in the socket site either as a 2 or 3 rooted molar, which is quite nice. It's better than snipping it all the way through, because then sometimes you can have a risk of the piece being dislodged or falling out from the suture. Again, I'll just mention 1 or 2 more products here, and then I'll move on to questions. But this is another great product, BioViva. If anybody's using gel foam on the line or this evening, this is a really great alternative to gel foam. It's a hemostatic gauze, but it really does control bleeding very, very well. It's extremely cost effective. It's around like $55 for a whole box, where I think if you actually looked up some of the pricing that you're paying for gel foam and some of the other products, I think you'd be surprised at how expensive it is. And we're finding this is another very popular product for us, where the reorder rate on this is very high and the feedback has been great. So it's another thing to take a look at if you're looking for something for bleeding control, or maybe if you're not grafting the socket site. Third molars, for example, this is a really good product for to prevent dry socket and to control bleeding. Here's the 2 membranes that we like. EpiGuide is probably our preferred membrane. That's on the left. It's a resorbable membrane. It's fully synthetic, but it almost acts as a non-resorbable membrane because it stays in place for so long. The EpiGuide is still our most popular membrane. I just wanted to mention that the EpiGuide is available, and it's something to take a look at. It's a larger sheet. It's actually 18 by 30, so a lot of doctors will actually cut it in half and use it for multiple socket sites. This is our bone, or our burr kit. So if you are going to do some of the cases that were demonstrated this evening, the burrs that are shown on the far right, those are really great for bone leveling. And then we have some degranulation burrs, which are going to be the first 3 shown there on the left. Those are really great when you maybe manually can't curette some of the granulation out of the socket sites. This is a good burr kit that will allow you to use it for degranulation of sockets, and then also for bone leveling. And then the burr that's there in the middle is just a good cutting type burr, or sectioning a tooth, or any type of cutting procedure. So that's something to take a look at under the burr section. I'm just going to skip through this real quick here. One last thing I want to mention is we do a lot of hands-on live patient training programs here in Detroit. They're under our Amplify name, so it's amplifydental.com. These really are a great hands-on experience. I mean, we see anywhere from 65 to 100 live patients during the programs. And you actually do get to do the surgeries yourself. So here's just some photos of some past courses here in Detroit at the University of Detroit. This is some of the hands-on component for the classroom during day 1. And then we move on to the clinic floor for day 2. Here, Dr. Nazarian, who's one of our instructors for the program, is just doing a live patient demonstration before we break out into the individual operatories. So you do work on live patients. There's no licensing restrictions as long as you're licensed in the United States or Canada, and you do work on live patients. So typically in a course like this, we'll extract anywhere from 150 to 350 teeth. We'll graft hundreds of sockets. We have 3 or 4 different programs now. We have our extraction program, which is AMP1, our extraction and grafting program, which is AMP2. And then we also have even a more advanced program, which is an immediate denture program, where you'll extract the teeth, level the bone, do a full flap, graft the socket, and prepare for immediate denture. So in our AMP3 program, you actually get to do, some of the cases without the implant component of it that Dr. Tischler was showing this evening, which is really great. It's all live patient. You're not doing it on a model. So that's really it for my portion. I'll just mention one more thing. We do 15% off, which is better than even trade show pricing. We don't discount our products that often, and we only do it for 24 hours. So if you want to take advantage of our special on some of our innovative products that you want to take a look at here at physicsforceps.com, the promotional offer is good for 24 hours. So I'll turn it back to you, Lauren, for questions, and I hope everybody enjoyed the presentation this evening.
Thanks, Kurt. And unfortunately, we don't have much time for questions. There's some webinars that we do where there's not a ton of content, and we've got lots and lots of time for Q&A. And then we have some like tonight where there's just so much great content that we just run up against it. And unfortunately, I need to get out of here. I've got a family thing going on. But Michael, I want to give you a chance to give any parting words before we say goodnight to everyone.
Yeah, Kurt, I'm really glad you showed all those products. You guys are a great company. I wasn't aware of the extensive nature of your training that Dr. Nazarian does up there. Hands-on is the way to go. I'm glad you showed that the putties that you have, and that OsteoPlug is a good product. I don't just say things like that. These are really good products. I think your elevators look great. I'd like to try some of those. Good company. Thank you for having me tonight. I really appreciate it, guys. It was enjoyable.
Well, thank you, and I'm hoping, and I'll throw this out to Kurt, that we can bring you back, because this was some great content, and I'm sure you only touched the surface of the things that you're doing on a regular basis, and there seems a lot of interest from people. So we thank you for your time, and thanks again to Kurt and GoldenDent for their sponsorship. They are so committed to dental education, and they bring on great speakers like Dr. Tischler, and really are committed to giving everyone the opportunity to improve their practices and improve their bottom line. So we do these webinars on a regular basis. I think we've got one with GoldenDent coming up in about 5 weeks or so. So you'll all be getting invitations for that in the next few weeks. And we look forward to seeing everyone on future webinars. So good night, everyone.
Thank you, Lorne. Take care. Thank you, Kurt.
Thanks.